Hey guys, thanks for watching my video. By now, most of you know that I'm working on my Doctor of Nursing Practice degree as a neonatal nurse practitioner. And as a part of the doctorate degree, we have to choose a project to do. So I chose mine on kangaroo care for our unit. So the title of my project is called Increasing Breast Milk Consumption Through Kangaroo Care in the NICU Setting. My goals and objectives are to implement and evaluate a kangaroo care program here on the unit, increase nurses' knowledge about both kangaroo care and breast milk, and we're not going to meet, but we're going to work towards meeting the Healthy People 2020 goal for breastfeeding. So the actual definition of kangaroo care is the act of placing a naked or diaper-clad infant against the mother's bare chest between her breasts for about an hour. 1 hour is the golden standard. Anything less than that and our babies are really not reaping the benefits. I should make another note and say that this is skin-to-skin contact. This is not baby skin against a bra or against a blanket or against clothing. This is baby's bare skin against mom's bare skin. So kangaroo care has a couple different benefits. The first category is neurodevelopmental. So it promotes neurological development by a couple different ways. It decreases maternal and infant stress. It regulates physiologic parameters such as vital signs, regulates the sleep-wake cycle, and it promotes breastfeeding. It actually promotes a deeper and a more restful sleep, especially for our preterm infants. So when that baby is going skin to skin and then is going back to bed, they sleep so much better and so much more, so much deeper, and that causes their brain to grow at a faster and better rate. Babies born less than 29 weeks gestation have only a third of the brain volume compared to babies that are full term. Their brains are also very smooth, so they're small and smooth. This puts them at risk for neurodevelopmental delays, cognitive delays later in childhood. So the decreased brain volume persists into childhood. It's not just something that these babies struggle with and then get over. It's something that they deal with their entire lives. So babies that do kangaroo care on MRI have bigger brains than babies that don't. And so this is really great for our babies, especially our preterm babies whose brains are already small. So if you do kangaroo care with them, you're going to be helping their brains grow better and bigger. Kangaroo care promotes neurological development and actually counteracts the effects of preterm birth. So when that baby goes skin to skin with mom, that brain is making a ton of different connections and the neurons are growing and getting bigger, and you are helping that baby's brain grow and develop. There are hormonal benefits to kangaroo care. It stimulates the production of two hormones in the brain. They are known as oxytocin and prolactin. Oxytocin is the first hormone. It's a neurotransmitter, and it's often called the love hormone. This is responsible for bonding, milk letdown, and stress reduction. What happens is oxytocin blocks the stress response and causes a decrease in catecholamines. These are our stress hormones that are made in the kidneys. And this decrease in catecholamines actually is what leads to the decrease in stress for both mom and baby, and can actually act as a protective measure against postpartum depression. Kangaroo care triggers the release of oxytocin, and the oxytocin acts as a buffer for the adrenocorticotropic hormone, the ACTH. And the ACTH is what produces cortisol. Cortisol is our one big stress hormone. So when that oxytocin goes up during skin to skin, that ACTH stops producing cortisol, so obviously the cortisol goes down. You can see that from a clinical standpoint in lab values. Prolactin is a second hormone that's super important during kangaroo care. It is the hormone that's responsible for milk production, breast maturation, and mammary gland development. So the way that it works with breastfeeding is that mom and baby do skin to skin, and that mom's brain starts to produce both prolactin and oxytocin in very high levels. So that prolactin is what is causing her to create more breast milk, and the oxytocin is what causes milk letdown. So the milk goes into her breast, and the mom is then either able to breastfeed or pump, which is the case in most of our babies. So evidence tells us that moms who pump after doing just 1 hour of kangaroo care produce 3 times as much milk as moms who do not do kangaroo care. So that's a huge increase just by doing skin to skin. Another study looked at preterm babies that were discharged on mom's own milk and found that babies that did kangaroo care, 77% of those went home on mom's milk, compared to just the 55% who went home on mom's milk that did not kangaroo care. So obviously another study that's showing us that kangaroo care increases milk supply. It's an effective way of promoting breast milk production for our moms, especially those who cannot breastfeed, which is the majority of the moms on our unit. Another cool thing is that kangaroo care exposes the mom to pathogens from the baby's skin. So what happens is that baby goes skin to skin, and that mom's body starts to produce antibodies to those pathogens, and those antibodies are passed along through the breast milk, and the baby receives the antibodies through the breast milk. So it's basically like being inoculated against all these diseases. In our NICU currently, only about 2.5% of babies on our unit do kangaroo care each week, so it's a super, super low number. Since starting my project a couple weeks ago, I started the beginning of June. Since then, the past 2 weeks, 27% of our babies are receiving kangaroo care on a weekly basis. So just in that small time frame, you guys have managed to drastically increase that number, which is amazing. Oh, one last thing is that there are about 1,000 NICUs in the United States, and only about 20% of them regularly participate in kangaroo care, despite all the evidence that we have. So all this data tells us that kangaroo care is so important for so many of the things that I've mentioned, but it's not being done consistently. And I'm assuming that's probably because there are a lot of barriers that we'll talk about. The physiological benefits of kangaroo care, these are our vital signs. So we usually see a decrease in heart rate, respirations, blood pressure. Those O2 sats go up. The baby is better able to regulate their temperature, so they come out of the box, so the ice let quicker. They usually have decreased FiO2 support on the ventilator. They also have fewer Brady's and DSATs. That's not to say that your baby that is doing kangaroo care is not going to Brady or DSAT, but it's going to be generally less frequent than it would be if the baby was just in bed. So like we talked about a little bit earlier, there are a lot of barriers to kangaroo care. The first category is maternal factors. So this might be, the parents aren't at the bedside, mom's not at the bedside, could be because of transportation issues. She might not have childcare. She might live a really long, far away from the hospital. But a big one that we've seen a lot is maternal fear. So moms are very afraid, and dads, they're afraid of touching their baby and hurting the baby because the baby is connected to wires and tubing and so many things, and they think that if they touch or if they hold, they're gonna hurt. So it's up to the nurses to educate and encourage these parents and tell them why kangaroo care is so important, and just kind of calm their nerves, because if we're confident, the parents are gonna be confident. The second category for barriers is nursing education. So kangaroo care is not routinely taught here at the CHM NICU. It's not part of new hire orientation. So new grads are coming onto the unit hardly knowing what kangaroo care is, if they know it at all. They might get a little bit of kangaroo care during some of their orientation, but it's not really talked about from a physiologic standpoint. A lot of nurses have a misconception that kangaroo care is just about bonding and it's nice for the mom and it makes everyone feel nice and happy. And these people are missing the point that it is vital for babies and for their development. Some studies looked at nurses who received education about kangaroo care and found that nurses who receive education via PowerPoints and it's part of their annual competencies have an increased confidence by 62% for doing kangaroo care, which makes sense. If you're teaching someone how to do something, they're going to feel more comfortable doing it. Staffing is perhaps, I would say, probably the second biggest barrier compared to parents not being at the bedside. So obviously, if your baby is not intubated, you can easily just pick them up and hand them to the parent, or have the parent just do it themselves. If your baby is intubated, you usually need at least 2 nurses at the bedside. If you're in a paired assignment, it can be tricky, as you know, because you have 2 babies, and initiating a transfer for kangaroo care is time consuming. It usually takes about 10 to 15 minutes to get that baby out of bed and situated with the parents. So it can be tricky when you're in a paired assignment. Also, if your pod is super busy, you might not have a lot of people around that can help you initiate the transfer. My goal of doing this project is to teach everyone the importance of kangaroo care so that when someone asks you to help with the transfer, you just get up and do it, even if you're busy. We're going to talk about breastfeeding for a couple minutes. Everyone knows that the American Academy of Pediatrics recommends exclusive breastfeeding for the first 6 months of life. The CDC does track this data, and in 2018 found that 83% of moms do start off breastfeeding. That number is super high, but by the 6-month mark, only about a third of them are continuing to breastfeed. So obviously this is different outside of the hospital than it is in the NICU. Outside of the hospital, fed is best. You do whatever you got to do for your baby. But in the hospital, breast milk is a vital life-sustaining resource for these babies, and in some places it's considered a medication, and these babies should absolutely be receiving breast milk. So the Healthy People 2020 goal, like we talked about at the beginning, is to increase the proportion of infants who have ever been breastfed, whether that's with mom's own milk or donor milk, to at least 82%. So this doesn't have to be baby goes to breast. It can be baby gets gavaged or baby drinks from bottle, but it's receiving breast milk of any kind to at least 82%. In 2018, the percentage of infants in the US who had ever received breast milk was 84%. In 2018, the percentage of infants in Michigan who had ever received breast milk was 85%. But in 2018, the percentage of infants at the CHM NICU who ever received breast milk was 24%. Much lower than the Healthy People 2020 goal, the national average, and the Michigan average. So we have a long ways to go. I will say, though, that this was the same year that our milk bank was created, so I anticipate the numbers being slightly higher. I need to get them from last year, but I would imagine we're probably around the 50% mark, I would say, so we still have a little ways to go. So we're going to talk about benefits of breast milk. Neurological benefits include the fact that it has long-term neurological effects on our babies. Children who are breastfed have higher IQs and increased cognitive functioning compared to babies that are children who are formula fed. Extra brain growth in breastfed infants is more pronounced in areas of the brain responsible for language, emotional function, and cognition. And breastfeeding increases white matter in several areas of the brain as well. So breast milk affects the brain in a positive way, almost every part of your brain in a positive way. And it's something that lasts throughout childhood. It's not, and well into adulthood, and doesn't just affect our babies and then that's that. The immunological benefits of breast milk are one of the most important factors of it. It decreases incidence of otitis media, which is ear infection, gastroenteritis, respiratory infections. Long-term breastfeeding is actually associated with decreased risk of cardiovascular disease, type 2 diabetes, and obesity. So it extends, like I said, well into adulthood. Another big thing you need to know are immunoglobulins. So IgG is an immunoglobulin that readily crosses the placenta, and it crosses in the third trimester. So immunoglobulins are these infection-fighting factors. They help create your immune system. So the IgG crosses in the third trimester, and IgG, IgM, and IgA are all found in breast milk. So when your baby is born in the second trimester, they're missing out almost completely on the IgG transfer. That means they have no immune system, and that's why they are so susceptible to infection and sepsis. So as a result, they are heavily reliant on breast milk for their IgG, their IgA, and their IgM. I think of it as GMA or grandma. Those are all the factors found in breast milk, and that is how the baby creates and develops their immune system. So secretory IgA is specifically important for preterm infants because it protects the gastrointestinal lining and helps protect against necrotizing enterocolitis. And breast milk has 4,000 times the amount of secretory IgA than formula does. The nutritional benefits of Kangaroo Care are that it has a ton of different ingredients. It's composed of growth factors, lysozymes, lactoferrin, proteins, fats, probiotics, human milk oligosaccharides, your immunoglobulins. All of these things help lead to improved digestion and absorption. It leads to faster gastric emptying, so that breast milk is moving through the GI tract much faster and not just sitting there like formula does. It results in better feeding tolerance, less residuals, and our babies on breast milk get to full feeds much faster. Breast milk has better protein quality and actually lowers the renal solute load, which means it's easier on their kidneys. But despite all this evidence, only about a third of babies across the United States in the NICU receive breast milk. Human milk oligosaccharides are our indigestible short-chain sugars. We do not digest them. They just sit in our gastrointestinal tract and coat it. So they are responsible for priming the gastrointestinal tract and creating a microbiome, which is why trophic feeds for our preterm infants are so important. It helps kind of wake things up. They act as prebiotics in the gut, not probiotics, but prebiotics in the gut that act as a food source for the good bacteria. So they encourage the growth of good bacteria and inhibit the growth of bad bacteria. So those HMOs are sitting in the gastrointestinal tract, they're attached to the lining, and it prevents the bad bacteria that might cause necrotizing enterocolitis from attaching, and instead that bacteria is just excreted. So as a result, HMOs are a protective factor against NEC. Another thing you need to know, and the difference between breast milk and formula, is that formula does not contain DHA, which is an essential fatty acid required for growth and brain development. It is sometimes added into the formula. You might see it on the label, but it is synthetic. It is not the same. Necrotizing enterocolitis, I'm sure we all know what this is. It is an infection of the bowel that causes widespread inflammation and can cause bowel perforation. It affects up to 10% of our very low birth weight infants, and mortality rate reaches close to 100% once surgical intervention is needed. So when our baby needs Penrose drains or a bowel resection, that mortality rate just climbs and climbs, especially the smaller they are. It accounts for up to 5% of our NICU admissions, despite the fact that it's considered a rare disease. Long-term adverse effects include short gut syndrome, feeding intolerance, cholestasis from the long-term TPN, dependence, strictures. All of those can potentially be prevented just by using breast milk. Oh, and then the cost of treating a single surgical case of NEC is over $500,000. So when our baby needs Penrose drains or a bowel resection, that's $500,000 that the hospital is spending that could be spent on other things and saved just by using breast milk. So how do we prevent NEC? There's no foolproof method. It's been researched for about 50 years, but the gold standard is breast milk, mom's own milk. Current data suggests that the breast milk is a protective agent against NEC. Our preterm infants that are breastfed are 6 to 10 times less likely to develop NEC. That's not to say that our babies that are breastfed are not going to develop it. It certainly does happen, but the incidence is only 1.3% compared to formula-fed infants where the incidence is 11.1. So obviously we can tell that formula is a risk factor for NEC. They're babies that are on formula, preterm infants on formula, are much, much higher at an increased risk for developing NEC compared to our formula-fed or compared to our breastfed babies. So let's talk about donor milk. Donor milk is great, it is phenomenal, but it is not the same as mom's own milk. It goes through an extensive testing and pasteurization process, which is important for safety, but unfortunately it results in the eradication of a lot of those infection-fighting factors. So your B cells, T cells, lymphocytes, all of those elements that are crucial for immune system development are eradicated. The IgA, IgG, IgM, almost all eradicated. And so donor milk doesn't really act as a way of helping the baby's immune system. It's still good because it is full of the human milk oligosaccharides, those HMOs, that protect and coat the intestinal lining and help protect against NEC, but it's not the same as mom's own milk. So let's talk about who's eligible for kangaroo care. For the sake of my project, we're not going to do kangaroo care on jets and oscillators. It is certainly done in other institutions, but they have supplies that make it a little bit easier. We're not going to do it during our kangaroo-a-thon. Other exclusion criteria includes babies that require frequent bagging on the vent or bagging, manual breaths, whatever, frequent boosts on the vent. Those babies are not going to receive it. That does not include our preterm infants that just go up and down because they have PDAs or whatever. Those babies are still eligible as long as they're not constantly braiding. Our babies that are getting workups for suspected sepsis, PPHN, generally because they're touch-me-nots. This is a newborn disease. So they come out of birth, or they come out, they're born, and they do not transition correctly. So they have PPHN. So these are our babies that are threatening ECMO. They're really unstable, just moving them or looking at them, and they just, desat and try to die. So we're not going to do it with those babies. ECMO, obviously, self-explanatory. Therapeutic cooling, infants that already have a fever, generally because their temp is going to go up with mom. And then fresh trachs. Everything else is fair game. So your UACs, your UVCs, your PICC lines, your EVDs, a baby in humidity, a baby with a chest tube or a Foley, that's all evidence-based. I will say for the UACs and UVCs, they have to be high-lying, they cannot be low-lying, otherwise it's easier for it to slip out. We know that babies less than 30 weeks gestation not only tolerate kangaroo care, but are actually more stable during it. So my little tiny 23-weeker baby that I did kangaroo care with tolerates it and is more stable. Not a single DSAT. You put her back into bed and it's just constant DSAT, one after another. And when she's skin to skin with mom, not a single one. Sorry, that's my dog in the background. Kangaroo Care does not increase the risk of a UAC, UVC PICC line dislodgement. It also does not increase the risk of an unplanned extubation. I will say, however, you have to do the transfer correctly. You have to watch the video and the demonstration so you know exactly how to move the baby and how to move the tube correctly so you don't extubate. Once that baby is with the mom and that tube is anchored and secure, that risk does not increase. You're not at an increased risk for an unplanned extubation. I know it's really scary, but that risk, according to data, does not go up. So to recap, being a tiny, tiny baby with a lot of wires and tubing, being intubated, does not preclude them from receiving Kangaroo Care. Kangaroo Care is just as important for our preterm infants as it is for our term infants. Term infants should absolutely be receiving Kangaroo Care as well. There's no cutoff date. The gold standard, though, is for the first 12 weeks of life when you're a term baby, and first 12 weeks of life, or 12 weeks of life corrected for a preterm infant. So our term baby should absolutely be receiving Kangaroo Care as well. We know that it's a safe and effective way of increasing milk supply, promoting bonding, creating a better neurodevelopmental environment. We see more stable vital signs, and it overall reduces morbidity and mortality for these babies. It's one of the best ways moms can increase their milk supply, which decreases the risk of NEC, and all babies have a right to Kangaroo Care if they are medically stable. So stay tuned. There's another link coming where you can watch the Kangaroo Care demonstrational video, and that will give you 2 different options for a sitting transfer and a standing transfer.